Great presentations, and we have the honor of having Dr. Nohad Ibrahim. He is a professor in the Department of Breast Medical Oncology at the MD Anderson Cancer Center, Houston, Texas, USA, and he is going to deliver us a lecture on anti-HER2 updates in the adjuvant setting. Please, Dr. Nohad.
Thank you very much for the introduction. I want to thank the presidents of this conference and the chairman of this session for giving me the time. Although I think 25 minutes is a little bit short, everybody ahead of me was over time. So take it into consideration. Adjuvant trastuzumab is probably one of the areas that was very efficiently studied in breast cancer, and as you see in the pivotal trials here, including over 13 or 14,000 patients, however, all concluded in 5 years, and they made a big difference on the natural history of the disease. When you look into greater details about these studies, however, you see that all have very different characteristics in inclusion criteria. However, they all contributed to the final conclusion that HER2 in the adjuvant setting is indicated and is the standard of care. And let us review this in greater details. The major studies that are summarized here, all indicative that giving adjuvant Herceptin improve the disease-free survival and the overall survival. But the duration of the treatment remains to be controversial, as well as when do you start it, with chemotherapy, after chemotherapy, i.e. concomitant, or in sequence, also is an issue that has been debated, however studied, and hopefully I can convince you with something today. When it was looked at 2 years versus 1 year, it was shown very clearly that the 1 year is the way to go instead of 2 years. If you give the Herceptin for 2 years in the adjuvant setting, you are only increasing with the side effects, particularly cardiac side effects, since the number of events showing that they are similar in both arms in terms of breast cancer behavior. So there is no point in giving it for longer than 1 year. With the 2 years, in addition to the cardiac events, you see also higher incidences of grade 3 and 4 side effects. And when you look at the cardiac toxicity, the acute toxicity, like acute heart failure, they are probably similar in the two arms, 1 versus 2 years, but the cumulative cardiac events that they call it acute or primary and secondary cardiac effects, such as any drop in ejection fraction, really rises significantly with the 2 years. So everybody now agrees that 1 year of Herceptin, not longer, should be enough. In another review about the 4-year follow-up of the patients receiving trastuzumab, 1 year, it continues to show that there is a significant improvement in the disease-free survival compared to the observational arm in the HERA trial, as well as improvement in overall survival, and this is a very welcome finding as well. In addition, it was found that in the observation arm in the HER trial, where the patients were given the option of being crossed out over to Herceptin, it showed that the patients who crossed over Herceptin at a median 22 months from randomization showed that there is a significant decrease in the disease-free events, suggesting that even patients who start later at Herceptin did not catch up with the wagon early on is still advisable and should be advised. Then how about the shorter durations? This study was done by Pivot and published in Lancet Oncology recently, comparing 6 to 12 months as a non-inferiority study, suggested that 12 months should remain the standard of care for patients, and 6 months is not enough. Mind you, this is a non-inferiority complex. Maybe a different design may show different results, but this is what we have to go by at this point in time, showing that if we have to choose between 6 and 12 months, we should be going with the 12-month duration. And here it shows the events of the 6 versus 12 months, showing that they are about similar. However, with the disease-free survival events, it's 13% versus 10% in the 12-month, and the distant recurrence is 8.3 versus 6.4 months. When it is looked at whether it's an estrogen receptor negative or sequential versus concomitant, or in estrogen receptor positive, all the indicators showing that the disease-free survival at 2 years were in favor of the 12 months rather than of the 6 months duration. The third question is the very short duration of Herceptin in the adjuvant setting, and the FINHER created a lot of turbulence here after we almost get used of using 1 year, and we were getting ready to probably extend it to 2 years, and the FINHER, the trial came in and say, well, maybe a much shorter duration is okay. And the FINHER trial here, when comparing in the neoadjuvant setting, docetaxel versus vinorelbine to be followed by FEC plus minus Herceptin, showed that the number one, that the docetaxel was better than vinorelbine, and number two, the addition of Herceptin also has improved disease-free survival in these patients. But this does not necessarily mean that the shorter duration of Herceptin at the present time is better than 1 year. And as Dr. Conti showed you with a nice slide summarizing all the ongoing trials with the shorter durations of Herceptin, and we are awaiting the results to see if we move shorter than the 1 year to a shorter duration. Dr. Perez also did a very nice retrospective review of the data to look at the sequential Herceptin versus concomitant Herceptin with the chemotherapy, and clearly the results as shown in this publication, showing that when we give Herceptin concomitantly with the taxane and follow on in the adjuvant setting for a duration of 1 year is better than completing the chemotherapy and start the Herceptin. And finally, about this, we're concluding that the absolute benefit of improving disease-free survival is about 11% based on the B31 and 9831 trial. Building on the very famous study of Dr. Dennis Sleman using adjuvant trastuzumab in the HER2 positive, it was built on this data to see if the addition of bevacizumab to trastuzumab may help improve the outcomes. This trial was presented at San Antonio this year, and the bottom line of which is showed that the addition of bevacizumab did not improve the disease-free survival or the overall survival. And then the summary slide of most of the trials that looked at the disease-free survival in this respect, showing very consistent results that the use of adjuvant trastuzumab really improve the outcome of the patients, whether they are node negative or node positive, although the benefits may appear to be a little bit better in the node negative patients. In ASCO 2008, this is a very nice slide showing this sector of patients who were really kind of salvaged by the use of Herceptin, and we want the darker yellow to expand and probably involve all of it. Now, the second question, since we agree at this point in time that the duration of Herceptin in the adjuvant setting is 1 year, the second question that bugs us all the time is, to who do you give it? Do you give it to the early tumors, 2 millimeters, 1 centimeter, 2 centimeters? Where do you put the cutoff point where you stop committing the patient for a longer duration of therapy. In British Columbia Tumor Registry, here looking at HER2 negative versus HER2 positive tumors, and 10-year relapse-free survival did not show any difference between the two. But this is not the only story. From MD Anderson data, and in collaboration with a couple of European centers as well, showed that the 5-year survival in the HER2 positive patients in T1A, T1B is 77 versus 93% in HER2. And in the NCCN trial, it is showing some trends that it is shortened survival. A French trial looking at the adjuvant trastuzumab-based chemotherapy in this group of patients, T1AB, and it showed that there is a significant improvement in disease-free survival for patients who receive adjuvant therapy. Obviously, the T1A were the smaller portion of the patients, but certainly it is going in that direction. And most importantly in this study, despite it is a retrospective study and despite that did not have enough patients, it showed that there is a trend that the patients who have LVI, positive LVI or ER negative, are those who benefited more, as shown in upper panel A and lower panel B, showing that those patients who really derived most of the benefits when they were treated with with adjuvant therapy. This is not an indication that these are the only patients should be taken, but should be given the therapy, but it is a clear indication that probably sometime we'll be able to subclassify the patients and see who would benefit and who would not benefit from adjuvant therapy. This study also was alluded earlier by Dr. Conti, looking at adjuvant paclitaxel and trastuzumab in HER2 positive smaller tumors. But again, here the definition of the smaller tumor differs, is less than 3 centimeters. May not answer our questions, but we're looking at the, let's call it now, very, very small tumors, but certainly it is intriguing study. I want to caution you that they did not use any of the standard of care adjuvant therapies that I listed in my first slide, and I will repeat it again. But look at node-negative patients, and they looked also at patients with normal ejection fraction. Only 20% of the patients were T1A, which is my problem because we don't know where to draw the line and stop giving therapy for these patients. But always, it's a nightmare in our mind that HER2 positive tumors carry poor prognosis if not treated. T1B were 31%. T1C and T2 comprise 50% of the patient. Again, disease-free survival was about 99% of the patients, relapse-free interval 99%, and disease-free survival by tumor size also was very high, in excess of 98%, very high grades. Disease-free survival by HR status also was very good, again 98 to 99%. I always say my mother was very pleased with me when I get 98 in the school. But where do you take this to? The median follow-up was 3.6 years, and there were only 2 distant recurrences for invasive local recurrences. So do we need to treat now all patients who are less than 3 centimeters, inclusive T1A and T1B? This is the conclusions drawn by the author, which are very, very nice conclusions, very conservative conclusions, but we need to build on that. Only 20% of the patients were T1A. We needed more. 67% were hormone receptor positive, which may also carry better prognosis. Did they contaminate the results or not? Really, we don't know. And more importantly, pivotal adjuvant trastuzumab studies or trial or regimen were not used here. So it says that not all patients require adjuvant trastuzumab-based chemotherapy. Thank you very much.